Welcome to this lecture on neuropsychology and cognition in DBS management. My name is Johanna Philipson and I'm a licensed psychologist specialized in neuropsychology. My clinical work is mainly within the DBS unit in Umeå. The field of neuropsychology emerged out of necessity, out of a need to better understand cognitive and behavioral implications of brain injuries and diseases. Through neuropsychology, we can better understand functional implications of brain pathology and surgical treatments. And by doing this, we can offer a better understanding of the relationship of brain behavior and in the end, improve quality of life for our patients and their caregivers. Many discoveries regarding brain behavior relationship have happened by chance. One of the most famous ones being Phineas Gage and the understanding of frontal lobe functions. Likewise, several findings within the DBS field have also been discovered by chance. One example being in 2008 when treatment of obesity by hypothalamic DBS was attempted by the Toronto group. During intraoperative stimulation, memory flashbacks were reported by the patient on several occasions. It was later revealed that the electrodes were placed very close to the fornix, which then raised an interest in attempting to treat Alzheimer's dementia with DBS. There are several similar discoveries, and this topic is addressed in a very interesting lecture by Professor Harris here on Stereotactic Academy. As we all know, several new indications, including psychiatric conditions such as depression, obsessive-compulsive disorder, etc., are under investigation, as well as the potential ability of DBS in improving cognition. However, the role of the neuropsychologist within the DBS team is primarily to establish whether an individual patient is a suitable candidate for surgery. The neuropsychologist should contribute to the decision regarding surgery by adding knowledge concerning cognitive status and psychological factors of importance to the post-surgical follow-up period. With DBS, we are implanting electrodes into the central parts of the brain. The implantation itself might cause tissue damage, leading to transient and maybe permanent side effects. It is considered good clinical practice to conduct a neuropsychological assessment preoperatively and 6 to 12 months postoperatively with the patient on medication and the stimulator activated. Cognitive effects after DBS have been investigated in a number of studies. One meta-analysis from 2015 consisting of 41 studies found that STN-DBS was associated with small declines in psychomotor speed, attention, memory, executive functions, and overall cognition. Moderate declines were found in both semantic and phonemic fluency. GPI-DBS resulted in fewer neurocognitive declines than STN-DBS. Both STN and GPI-DBS were found to produce subtle cognitive declines, but appeared to be well tolerated. In patients with essential tremor following thalamic DBS, other studies have found declines in general cognitive functioning, attention, executive functioning, visual perception, and memory. The most consistent finding across studies are moderate declines in verbal fluency. Some evidence suggests that the cognitive effects of STN and GPI-DBS in patients with dystonia are less significant than for Parkinson's disease. Although a minimal amount of well-controlled research exists, the GPI is sometimes considered better tolerated for patients with impulse control disorders and psychiatric difficulties. Since there is a lack of consensus and clarity regarding the extent of caution that should be applied in mild to moderate cognitive impairment, the importance of a multi-professional team when determining a person's suitability for surgery cannot be stressed enough. The main reason for multi-professional perioperative assessments is to determine whether the patient is suitable for surgery. The role of the neuropsychologist within the DBS team is to assess cognitive and emotional aspects of importance to be able to make this decision. There is a widespread but not substantiated belief that patients with cognitive decline before surgery are at higher risk of cognitive deterioration due to the surgery itself. It is, however, more likely that it's not the level of cognition itself, but the presence of an ongoing deterioration that is to be considered a risk factor in this matter. Therefore, patients with intellectual disabilities might very well be candidates for DBS, provided that their level of cognition is stable. One important aspect of the preoperative assessment is to determine the patient's capacity to consent to surgery. As DBS is often used as a last resort, patients may be unduly influenced by desperation or even pressure from family members. Patients may also believe that nothing could be worse than their current situation. However, perioperative complications and stimulation-related side effects could lead to the situation deteriorating. These are all important aspects to discuss with the patient and with family members or caretakers. Apart from when bilateral stimulation in the STN is planned for DBS in Parkinson's disease, there are no established exclusion criteria with regards to cognitive impairment. Cases should, however, always be considered on an individual basis, and the presence of mental health problems or cognitive difficulties are no absolute exclusion criteria. When facing borderline results during neuropsychological testing, it is important that patients are not prevented from accessing beneficial treatment, but we also need to be aware of the potential risks involving patients with cognitive deficits or emotional risk factors. We sometimes note that patients undergoing DBS appear to be lacking concern regarding stimulation-related side effects and focus more on perioperative complications, even though the side effects are more likely to impact postoperative satisfaction with the treatment. Patients sometimes also overestimate the pace of postoperative change and underestimate the demands placed upon them in the post-surgical period when stimulation settings are tried out and evaluated. These are all issues that the DBS team need to address not just once, but several times during the preoperative assessment. It's well known within marketing and communications that we need to have a message repeated several times before we accept it as a fact, and maybe this is also true for medical information. Several studies have highlighted the discrepancy between outcome of motor symptoms after DBS and patient satisfaction. Improvement in motor symptoms does not always correlate with patient satisfaction. And as psychologists, we are responsible for identifying our patients' goals and expectations of the treatment. Sometimes this issue needs a little deeper probing than a simple questionnaire. So apart from the cognitive assessment, neuropsychologists within the DBS team should also make a contribution to selection, management, and post-operative care of potential candidates for DBS. An important part of the pre-surgical assessment is, as mentioned earlier, to probe for patients and caregivers and/or partners' expectations of the surgery. We need to be aware that patients and caregivers may not always let us know what they're actually hoping to achieve with a DBS surgery. Unrealistic expectations may be either consciously or sometimes unconsciously withheld in order to favor the selection process. Several studies and clinical experience regarding DBS in Parkinson's disease clearly show that impairment and disability may not always correlate. Therefore, the results of DBS may differ depending on what aspects we assess. Are we focusing on the patient's symptoms, their general disability, or their ability to cope with the current situation? When evaluating the effects of DBS, we have to take into account at what point in time we're conducting the evaluation when we consider the results. When postoperative assessments are done within a few months after surgery, most patients usually report that they're doing well. This may be a genuine effect of the surgery, but it can also be due to the fact that they're feeling relieved that after months or perhaps years of anxiety and built-up expectations, they have now finally gone through with the surgical procedure without major harm. One study showed that the clinical benefit was reported as heightened when the patients were advised that the stimulation was on. They also showed that clinical worsening was reported when the patients were advised that the stimulation was off. This is one of the reasons why we may need to address the possibility of placebo effects. When the evaluation is performed at a later stage, perhaps several years after surgery, the natural disease progression also has to be taken into account. In general, a neuropsychological assessment will initially include a clinical interview and a review of medical records, including neuroimaging and lab results. The referral question will then guide the neuropsychologist in selecting what type of evaluation will be made and what tests to include. Most neuropsychologists today will choose a flexible test battery based on individual patient needs and the aim of the assessment. At our DBS unit in Umeå, we have chosen to use a rather fixed test battery. This is mainly because we often have study protocols to follow in some of our patient groups, and in addition, the vast majority of patients have some form of movement disorder. We therefore have to adapt the test battery in order for it not to include too many tests depending heavily on motor function. A comprehensive assessment should cover the main cognitive domains, preferably at least 2 different tests per domain. But what specific tests are chosen will of course depend on availability in the clinical setting, as well as the knowledge and experience of the assessor. It's often recommended that we get well acquainted with the tests we use, rather than having a multitude of tests that we have little experience in using. With in-depth experience of the tests used, we will be able to make a better interpretation of the test results. To date, there is no consensus on a golden standard test battery when assessing eligibility for DBS treatments. The test battery will, however, need to be short enough to be tolerated by patients with fatigue. The tests chosen should also be sensitive to cognitive difficulties, typically associated with the condition being treated. There are also other factors to be taken into consideration, such as local availability of tests, range and quality of tests, as well as the need to assess all the major cognitive domains. Given the requirement for a follow-up assessment after surgery, the availability of parallel forms in order to manage retests effects and possible impact of practice effects are of importance. In addition, we need to estimate premorbid function to make assumptions of cognitive decline. Several approaches have been devised to estimate premorbid cognitive ability in neurological patients, including best performance on so-called hold, no-hold tests, demographics, reading ability, and combinations thereof. Typically, vocabulary and information from the Wechsler scales are commonly used as hold tests because they're considered resistant to neurological and psychological impairment. The remaining core subtests measure no-hold abilities and are more susceptible to neurocognitive impairment. Scores on tests requiring the reading of phonetically irregular words, such as the National Adult Reading Tests, are highly correlated with general intelligence in a healthy population, and reading ability of irregular words has also been shown to be resistant to neurological impairment and age-related cognitive decline. In Umeå, we have chosen to use a Swedish version of the National Adult Reading Test in combination with demographic information as a base for estimating premorbid cognitive function. Currently, we're using the following tests in our standard assessment battery when evaluating patients with movement disorders such as Parkinson's disease and essential tremor. These are all tests that are widely recognized and validated both internationally and in Sweden. They're also locally available and have reasonably updated and current normative data. Most of them, such as the Ray Auditory Verbal Learning Test and the Brief Visuospatial Memory Test, in particular, have parallel versions that can be used for follow-up assessment. The exceptions to this rule are the DCAF's color word interference test, the Tower test, and the Swedish National Adult Reading Test and DigitSpan. However, most of these tests are less sensitive to test-retest effects, particularly since we normally do our follow-up assessment after 12 months. In addition, we're generally more concerned of test-retest effects when assessing memory and learning. When selecting which tests to include, we've tried to minimize the impact of motor skills and speed. Therefore, tests with high degree of reliance on psychomotor speed, such as the symbol digit modalities test, has been less prioritized, as well as tests of attention that are dependent on motor reaction time, as our most continuous performance tests. We did use an auditory-based attention test initially, but this had its own set of possible confounders since hearing loss is an issue in the elderly population, and the majority of our patients would qualify in that group. Apart from assessing cognitive status of the patient, we should also address emotional and behavioral aspects. There are no explicit exclusion criteria with regards to mental health issues, but we know that untreated mental health conditions such as depression or apathy in Parkinson's disease may have a negative impact on compliance and also increase the risk of adverse events. Adverse events can include cognitive and psychiatric problems, as well as more motor-related issues such as balance, gait, and speech. Therefore, we should include screening measurements for depressive symptoms, anxiety, and apathy. And in our department, we commonly use the Beck Depression Index, or the Beck Anxiety Index, and the Starkstein Apathy Scale for this matter. We should, however, also remember that the clinical interview during the standard cognitive assessment is an excellent source of information where we can pick up on thoughts and feelings that are easily missed if we rely solely on self-report questionnaires. Depression and apathy have previously been regarded as contraindicative of DBS. In Parkinson's disease, apathy and depression mainly relate to progressive serotonergic and dopaminergic denervation. And these symptoms can be observed even in the early stages of Parkinson's disease and often increase as the disease progresses. Symptoms of apathy are also common after bilateral STN DBS, and they're thought to be related to postoperative decrease in dopaminergic medication. However, unilateral STN DBS, together with a less profound and slower reduction of dopaminergic medication, have been shown to lead to relatively stable or only slightly worse outcomes in postoperative mood and apathy. So in an RCT comparing STN DBS to best medical treatments and evaluating apathy as a secondary endpoint, there were no between group differences in apathy over the 2-year follow-up period. And this should support the idea that postoperative apathy is not inevitable and it can be responsive to medical management strategies. No single clinical factor has been clearly identified to predict the occurrence of postoperative maladjustment, but realistic versus unrealistic expectations seem to be of importance. Postoperative social maladjustment following DBS has to some extent been attributed to what has been commonly called the burden of normality. And the burden of normality has been described in patients suffering from severe chronic diseases who after treatment dramatically improves their clinical status. It's characterized by psychological, behavioral, and social function disturbance. The experience of such a rapid improvement of symptoms in these cases is then followed by an inconsistency in perceived self-image and identity, as well as a difficulty in abandoning the former impaired status. The new normal condition might create a need to fulfill life events that have previously been missed out on. The idea of this condition, burden of normality, is that the psychosocial maladjustment is a result of the individual's negative beliefs of their medical condition and unrealistic expectations of the treatment, which in turn affects the change between pre- and post-treatment. The root cause is, however, thought to stem from the pre-treatment period. So in order to better handle the social maladjustment, especially in patients with Parkinson's disease undergoing DBS treatment, a multidisciplinary psychosocial preparation of patients and their families is recommended. So where do we draw the line? When is the right time to raise a red flag, signaling that DBS perhaps is not the best option for advanced treatment due to the cognitive status of the patient? Well, to date, there is no consensus with regards to mild to moderate cognitive impairment. When there is evidence of dementia, there is a risk of interference with post-surgical management and limited gains in quality of life. There's also the aspect of whether the patient is able to give informed consent. Do they understand the risks and benefits of the procedure? However, the patient's best interest should always be at the center of all decision making. This is why the importance of a multi-professional team cannot be stressed enough. The combined assessments of all team members should be discussed for a well-grounded decision to be made regarding the eligibility for DBS. At our unit, we tend to be more willing to offer DBS treatment when the patient is presenting with tremor and the suggested target is unilateral zona incerta or VIM stimulation. This is also the case regarding bilateral pallidal stimulation in patients with dystonia. But when it comes to bilateral STN DBS in patients with Parkinson's disease, we do prefer to avoid patients who present with multi-domain MCI during the neuropsychological evaluation. However, we argue that stable cognition is of greater importance than the actual level of cognition. There are documented cases of DBS in patients with intellectual disabilities where the postoperative evaluation show no worsening of cognitive function. So with that, I thank you for your attention and leave you with this short summary and some bullet points. So the role of the neuropsychologist within the DBS team is primarily to assess cognitive and emotional aspects of importance to determine whether a patient is suitable for surgery. It is considered good clinical practice to conduct a neuropsychological assessment preoperatively and 6 to 12 months postoperatively. As of yet, there is no consensus on a golden standard test battery when assessing eligibility for DBS treatment. Choose tests that are locally available and tests you have knowledge and experience of. Remember to address emotional and behavioral aspects and probe for expectations of the treatment. And in the end, it is the combined assessments of all team members that will provide a well-grounded decision regarding the eligibility for DBS. Thank you.